So I'm just gonna say it, you might hear it from your class advisor, you might not. If you're parking in the main parking lot, please stop and don't park in the big parking lot that's right here, park where you're supposed to. Because I'm not saying here, I don't know who, but I have students in general, some of them have been parking there and it's been getting noticed. So if it's you in here, hey, just park in where they told you to park in indoctrination week. Yeah, so I already talked to the freshmen because they're mine. I walked in before their test. I was like, it better not be you. I just told you 2 weeks ago, don't do it. So it's probably those damn seniors, let's be honest, right? They don't care anymore. They're on their way out. They're taking a skin test today. They're doing whatever. So, all right. Any questions about what we covered like 72 hours ago? No. Did any of you actually look at it a little bit? Good. I'm getting some north and south. I appreciate that. For those of you that didn't, I also don't blame you. But okay. So we're gonna jump in here, lumbar spine, right? We're gonna talk about a lot of the same things that we already kind of did with the cervical and thoracic. We're just gonna see what that looks like with the lumbar and things that we covered. So like I said, it's the part we go a little bit quicker because we spent so much time looking at how to find those abnormalities on those earlier slideshows and how to recognize them. Now we just talk about them a little bit more, see what they look like there, and go over it that way. Where's your anatomy? It's the lumbar spine from last semester. No, it's making your friend. There's the muscular areas that all attach to different spots. And where most of your problems actually come. It's rarely bony, it's usually muscular. Everybody wants to know why. Okay, so let's take a look at this now. This is your normal x-rays. I have them nice and labeled for you. On an exam, if I need you to name a lumbar vertebrae, I will not be labeling them for you. Why? Because we have tips and tricks that we can do to count them ourselves, just like the cervical spine. We'll start with the lateral, because the lateral is the one that's on the left, and that's how we read this complete. So, here's the sacrum. See what the sacrum is shaped like? Now in pediatrics, it'll look a little segmented until it fuses, right? But you can still see the general shape of the sacrum, so you'll be able to kind of notice where that's at, and then you just count upwards from there on your lateral. So if that's my sacrum, and I got L5, L4, L3, L2, L1. Why do I do that? Well, because it's really hard to tell on the lateral which one of these vertebrae has a rib attaching to it or not. It actually almost looks like is that a spinous process? Is that a rib on L1? I don't really know. It's kind of hard to tell. So that's why we go from the bottom and count up on the lateral, because the sacrum is the sacrum. Then there's no confusion in that aspect. Okay? So that's why we'll do that. Now on the AP, I can clearly see the last vertebrae with the ribs, right here. They're coming off. 12th rib, there's my rib. I got nothing coming off of this one. So if that's the last vertebrae with ribs, we know there's 12 vertebrae in the thoracic spine. That becomes T12. The next one down becomes L1. And then I go 1, 2, 3, 4, 5. Because look what's kind of really hard to tell on the AP is kind of where is that 5, S1 sacrum junction? Bless you. It's kind of difficult, but I have that 12th rib on that T12. So when I do the AP, I count from the top down. When I do the lateral, I count from the bottom up, which, you gotta love this, complete opposite to what we learned with cervical spine, right? Cervical spine, the lateral, you count from the top down based off of the spinous processes and going down that way. On the AP, you count from the bottom up, looking at that first rib for T1, and then going up that way. So it's flipped, but it's just based off of, if you just think about what can I see on this x-ray based off of the anatomy, then you'll remember and kind of know how to count that going forward. Questions on counting the vertebrae? Okay. So here, it looks like this L5-S1 joint space is a little closed off, right? We talked about how the disc spaces are larger in the lumbar spine. So the question is that normal or is that abnormal? Well, I put normal radiograph on the slide. So it's normal. And you're like, well, why? Why isn't it big? Because if you think about the way an x-ray will work, right? We talked about it briefly. There's not just one beam of radiation coming down onto the patient, right? It fans out. It gets the whole picture. So what ends up happening is your center is usually right around L2, and so it's a game of shadows, right? So you have one beam, and then the other side beam kind of project down like this, kind of like a fan, right? As if you would light. The light doesn't come straight down, it fans out. So what you end up happening when you're at the L2 area is there's some beams that are fanning and it's projecting the bottom part of L5 into that joint space a little bit, right? So that's when you're like, okay, well great, we just learned all this, so how do we know? Well, the good news is when you guys get lumbar spine x-rays, because we know this from a medical standpoint, all of your protocols, you don't have to remember to order this, it's automatic. When you get a lumbar spine, you will get the AP, you will get the lateral, and then they will do a specific spot of this joint space called the L5S1 spot, and they come down and they just give you that joint space so you can get a true representation of what that looks like, especially if you're concerned about a patient who may have an abnormality in there, right? Other things I can do if I was concerned about degenerative disc disease is look for osteophytes or other things. The odds of it handling one area in the lumbar spine is pretty rare. It's usually going to be in multiple areas. But that is something that that's why that is so thin there. It's that convergence of the x-ray beam projecting that down into that joint space a little bit. Yes, sir?
Sir, so for L5, the inferior portion, it kind of protrudes out, that's normal?
Yeah, so normal-ish, right? Every patient's going to be a little bit different. What would I consider with this? Well, what's the patient coming in for, right? Why are we doing it? Is there pain down in that area? But yeah, so I can see what you're talking about this little, you come on down here, you're talking about on the top.
The inferior portion.
Here? Yeah. So my question then would be, where's my L5S1 spot? How does it look there? Could that be a projection? Because you'll get some younger patients too that don't even have that at all. It's just pretty little perfect vertebrae. It just all depends. Yeah. Mm-hmm. Okay. So now I just get done telling you that, and this is where I tell you, the younger patients, right? Look at how big and open that L5S1 disc space is. They're younger, so sometimes it projects really nicely here. Okay? This CT is not the same patient. Just showing you what a normal CT looks like. It's not the same patient. Because look at my joint space here, my L5S1. It's a lot thinner, right? But still normal. Don't have any major closing of this space in this area. I don't have any osteophytes that I can really see. Yes, sir?
When you say young, are you talking, is this like, would this be a peds or a teenager?
Yeah, so younger, so like early 20s, right? Not a peds yet because my sacrum is fused, right? I have one bone. So if I had what looks like a section and then like a disc space and a section and a disc space, right? Then we'd be talking peds because the sacrum hasn't fused yet. Yeah. So I say younger, it'd be like 20 something compared to like 50 or 60 or something along those lines. But there's my CT. How do I know it's a CT? Primarily with the spine. Look at my spinal canal. It's all the same color. It's all the same density. I can't make out the spinal cord or the CSF or any of that stuff. So that's what's telling me that. Here's an MRI. Alright? Normal MRI. Don't really have, biggest thing for you guys, don't really have any major disc bulges. For those that are looking at it, and our sharpshooters kind of like, ooh, there's a little bit right there. No, don't get hung up on the little lump, right? The body's not perfect, right? We don't have any significant bulging in that spinal canal. You may get just a little bit here protrusion, but that is not a bulge. Look at all that CSF going into there. Why? What are all these striations down here? No, so think about it, right? I got the CSF, which is the white. So look at these striations right in here. Cauda equina, right? This is where that spinal cord starts to split and becomes those fibers, that cauda equina. This is why when we do lumbar punctures, we do it in this area of the spine. Because it's not the spinal cord anymore, it's starting to separate into just those nerves. I got you this one second. Right? And so they move out of the way really easily. So when the needle goes into the spinal canal, it just pushes the cauda equina area out of the way because it's in that fluid CSF area. And this is why we do our lumbar punctures in this area right here. Yes, sir?
The L4, L3 area, is that the osteophytes starting to develop there towards the end? Is that more of a normal finding?
Yeah, probably more of a normal finding, right? Maybe, right? I would, this guy's pretty young and pretty healthy otherwise, so don't overread, right? I'm not looking at, giving you a subtle, hey, this is literally the very first only abnormality of degenerative disc disease. Pull it out. That's not what we need you to do. We need you to notice it when it's there, not when it might be there, for that kind of stuff, right? So, no, I would say that for this patient, this is pretty normal. And how do I know that? Why did I get the x-ray? Why am I coming in? If they're a 23-year-old, degenerative disc disease shouldn't even be on my differential, right? Unless for some reason they had some major spinal surgery at 21 or something like that. Shouldn't even be on my differential for a 23, 26, even 30-something-year-old. If I have a 50, 60, 70-something-year-old, then maybe degenerative disc disease, because what is it? It's mainly arthritis of the back. Now I'm fitting that patient population a little bit more, right? Why am I getting the x-ray? What's going on? That'll help you distinguish between should that be normal or not. Yes, ma'am?
Can you adjust those age numbers, sir, with active duty? Like I've had airmen that had like that 20s.
So yes, you can, right? And I'm talking in generalities, and that's why I say everything's patient specific, right? So then my next question is active duty, 27 years old, what was their MLS, right? What had they been doing? What was their, if they were a jumper, we got a whole different ballgame, right? At 27, degenerative disc disease is absolutely on the table with somebody who's been a jumper for 9 years, right? But if they're admin or if they're medical, probably not on the table for those guys, right? So what is your MLS? What is the patient history? Yeah, right? Common thing. Never and always. Don't use it, because the second you do, that's when that patient's gonna walk in, right? All right. Oh boy. Oh boy. What's going on here?
He's got crows. He's got a vulture in his leg.
He's got a vulture in his leg. Why in the heck is there a fractured calcaneus in my lumbar spine section? It has to do with the question on the bottom.
Wrong slide.
Not wrong slide. Good guess. What other injuries? The amount of force that it takes to fracture a calcaneus is immense, right? And that energy has to go somewhere, and it typically goes up. If you ever have a patient who comes in because they fell, maybe their back's not hurting, but they're really hurting on their foot, they fell from a high location, they jumped, or whatever the case is, and you find a fractured calcaneus, you need to order a lumbar spine next. Because a large majority of the time, there is also a spinal fracture or or some kind of lumbar abnormality that has gone along with this injury because of how much energy it takes to fracture this. This is one of the strongest bones in your body. It is so hard to fracture because of where it's at, the directed impact you would need, and the thickness of that calcaneus. It is designed to be weight bearing. It is not designed to break. If it does, the odds are there's something else wrong. You should need a tib fib, but more importantly, a lumbar spine, because that's the area that often gets overlooked with these injuries. And then we end up seeing, potentially, something like this. Positive yellow arrow sign. Right? Would you say this image with the yellow arrow looks osteoporotic? Good. I agree, it is not, right? So this is some of those areas now. Why did this happen, right? Why did this happen? You don't have osteoporosis, or at least it doesn't look like it, right? But you have a compression fracture. Now, if I got this x-ray because of that picture, I've got my answer, right? I know why it happened. It happened because of that. But if I don't have an injury, and I just got the back pain, now what am I thinking? Some type of malignancy, right? This should not compress on a non-osteoporotic patient without some type of major trauma if they haven't had any, and if they did, now why? Why is that vertebrae compromised? And that is the cases when you would jump to an MRI as that study of choice for the compression fracture to figure out why. When you go back to that compression fracture slide, those are the ones we're talking about of study of choice.
Could it also be a like infection?
It could be an infection, it could be multiple things, right? But when I do the MRI, it'll tell me if there's that soft tissue mass in there that's not supposed to be there, and will also show the inflammation from an infection potentially as well. because when we talk about infection in the bone, you're talking about osteomyelitis or septic arthritis. You go back to those slides, what's the study of choice for those? It was MRI, right? So that MRI gives us all of those answers on an otherwise healthy patient without trauma who has a compression fracture who's not osteoporotic. I want to know why, because this should not happen in healthy people. Good. All right. Burst or compression fracture. What do we think? What do we think? So typically our compression is going to be in kind of one area, right? Those that we'll go back to here. We got our anterior superior area. But I got fracture up through the bottom as well. You can see the fracture up through here. Piece off here. So what this is a burst fracture. But if you weren't sure, what other kinds of information would help you to sort through that potentially? What's the mechanism of injury? High impact, low impact. What is their impact? Right? Was it a traumatic experience, a traumatic injury, trauma, or do they just have osteoporosis? So looking here on these two, would you argue osteoporosis? Maybe it's kind of borderline, right? I can see an argument for either. When I have my normal CT and I look at my other one, I can see kind of either. So now I would shift to what's my mechanism of injury. If I can't tell through here, but I also have fracture going through this area, we have the fracture up here, so we have a common unit of fracture, right? And this is just one slice, so it's kind of, I know it's kind of hard to tell, but I just wanted to show the fracture inferiorly along with the other areas. So if I mix the mechanism of injury with the picture, with the cause potentially of what's going on, that's where we can kind of figure out compression versus burst. Also kind of shifting more posterior into the spinal canal, right? Our compression fractures affect down here don't usually go posteriorly, but the burst can. Yellow arrow sign again. Yes. And so rich disc space is being bulged or herniated or whatever word you want to use. L4, L5. Sacrum, L5, L4. L4, L5. Sacrum, L5, L4. There it is. Cool. What's going on here? What's the diagnosis? So it's not subluxation, spondylolisthesis, right? Because it's the spine. We don't use subluxation when it comes to spine. From definition, maybe I might buy that, that's fair. But we have a specific name for it when it comes to the spine, and that's the spondylolisthesis. And we'll not be giving you subluxation as a choice for spine stuff on the test, just to avoid the confusion, but it is spondylolisthesis of what area? Okay, so L5, S1, sacrum, L5, and anterior, because it's named from the direction of the superior vertebrae. So sacrum, it is pediatric, L5, L5S1, anterior spondylolisthesis. Did everybody see that? Okay. Questions on the lumbar spine? Pretty straightforward when it comes to stuff we already talked about. Compression fracture, burst fracture, osteoporosis, right, and the spondylolisthesis. And the bulging disc or herniated disc. Now let's talk about the pelvis. All right, so this is the pelvis. Here is the anatomy. There's an inner ring, there's an outer ring. Okay, remember that from A and B. There's all your ligamentures that kind of come together and all your bony abnormalities. There's your x-ray. Okay, use this x-ray to recognize what normal looks like. That little divot in the femoral head is the fovea. That is normal. That is normal. That is the fovea. Okay? Know your lesser trochanters, know your greater trochanters. Alright? Your SI joints. Pay attention to those, where they're at and how they're shaped. SI joints are not fractures, those are normal. They could be widened, which then makes it a fracture, kind of like the physes in pediatrics. So understand what it's supposed to look like. Same thing with pubic symphysis. That is a joint space there, pubic symphysis. But it could be widened depending on what's going on, so understand what your normal pelvis looks like. Pediatrics. I am not going to give you a pediatric pelvis and have you try to figure out if these are fractures or if these are normal. But I don't want it to be the first time you see pediatric x-ray in some of these areas. It is like, these are not fractures, this is not osteomyelitis, it just hasn't grown together yet, right? The whole pelvis has not come together yet. Another pediatrics for your frog leg, what the frog leg basically is a bilateral, lateral view of the hips, right? So you get your AP view, and then we want to see the lateral view. You can't really do a lateral pelvis, and really want to give us a lot of information. That's a huge thick bone, there's not a whole lot that we can get from that, so we make them do lateral legs. They just bend their knees up, let it fall out, and they take a picture, and it gives you like a lateral picture of the hips. Normal CT, I want you to focus on the bony areas, right? This is contrast. This is somebody who drank contrast. This is for the intestines, but we're focusing on the pelvis in this section. So just know what a CT looks like, and then we'll talk about what we're looking for. This is an important slide. There are a lot of words here. Again, 2/2 means secondary. Okay. Pelvic fractures. Very concerning. Okay? Because often what happens is somebody will come with a pelvic fracture and they'll be stable and they'll look good and everything will be fine, when in reality they are bleeding into their pelvis. Most of your pelvic fractures that cause bleeding are actually caused by rupture of the venous plexus. It is not an arterial bleed, it is a venous bleed in the pelvis. The pelvis can hold 4 to 6 liters of blood. So there is a lot that it can hold before that patient starts to present vitals or signs or symptoms that there's something going on, which is why pelvic examination, as far as imaging goes, on trauma is super important, because you need to know whether or not there's a pelvic fracture there, okay? So you may be able to tell by physical exam, by doing the old kind of shaking the hips and see if you get like, movement or cracks or, crepitus and all that, the open book, closed book type stuff. You might be able to, but if it's just a singular fracture and it's not a full pelvic fracture, as far as an unstable pelvic fracture goes, you might not get movement, right? Because it's still stable. So, what do? Yellow, pelvis x-ray, initial study, period, end of story, right? Doesn't matter if the patient's stable or not stable, I am doing a pelvis x-ray because I can get it right then and there, and it can give me information that I can go through, and once I learn this, be able to review and look for any fractures in the pelvis, okay? After the pelvic x-ray, if I'm looking for study of choice, it depends. If they're stable, I send them to CT, because it's detailed, it's more information, I can give them contrast, so write in your notes with contrast, because the idea is I'm concerned about bleeding. So I want to be able to see if there's bleeding in there, right? So if they're stable, with contrast, okay? But I send them to CT with contrast to check on any type of pelvic fractures, any type of genitourinary injuries, intestinal injuries. I can see it all. I can see the bladder, right? I can see the bladder's ruptured. I can see all this stuff when I do the CT. If they're stable. If they're not stable, if they're unstable by the vitals, right, or how the patient is presenting, we don't send them to CT, because what happens in CT? Patients die in CT, right? So we don't send them. We do the fast exam. That's an ultrasound. We are going to cover that more in block 2, but you need to know trauma, concern for pelvic injury because of the trauma, unstable patient, EFAST. Fast exam. Because what you're doing is you're just looking for free fluid where it shouldn't be. That tells you that there's internal bleeding. You'll check between the liver and the kidney. You'll check between the spleen and the kidney. You'll check the bladder area. You'll check the heart. You'll check all these areas really quick that you guys can do bedside. While other life-saving techniques are going on, this does not have to wait. right? Real clinic life, you're doing it simultaneously. The x-ray is happening while you're doing the fast exam. But for the sake of algorithms, x-ray is the initial study always. You have to get the pelvic x-ray. Then when you're trying to truly evaluate, is there more injury, is there more damage, CT versus fast exam, stable versus unstable. Questions on that? Now, you're right, for those who are thinking it, and I've been asked before, well, what good is the fast exam if it's not looking at the pelvis? I'm concerned about a pelvic fracture. You are, but you're concerned about a pelvic fracture that has caused internal damage, causing bleeding within the abdomen. That's what we're more concerned about. So when we end up seeing fluid where it's not supposed to be in a trauma patient, that is blood until proven otherwise. We treat it like somebody who's internally bleeding. We don't know where most of the time. We just know these areas where there's not supposed to be fluid, and if it pools up, they're bleeding from somewhere. So it's likely going to lead to surgical exploration to try to figure it out, try to find the bleeding, find the source, and stop it. But that positive fast exam versus negative fast exam can turn around and go, I need to call surgery versus I don't need to call surgery. Does that follow? Okay. So that's what all these words are saying. X-ray first, then CT with contrast, or fast exam, depending if the patient is stable or unstable. I even made a fun little algorithm for you. So, concern for pelvis fracture, plus or minus pelvic x-ray. What that means is, whether you have the x-ray or not, x-ray is still the initial study to do, right? Whether the x-ray is positive or negative is what I'm getting at, right? You've gotten the x-ray. It's not like whether you get it or you order it or it's positive pelvic x-ray, I found a fracture, or negative, I didn't see a fracture, right? Regardless of the results of the pelvic x-ray, you will be doing either a CT or a fast exam on this trauma patient. Because what if your x-ray is negative, but you just didn't see the fracture, right? We're not just gonna marry ourselves to, we still get the x-ray, because we need it, but regardless of the results, your next study, your study of choice, your definitive study, whatever you wanna call it, is gonna be fast or CT based off of stable or unstable. Don't worry about the angiography and the laparotomy right now. That's for another course. That's further on, depending on your fast exam results, what you can do further on in that aspect. I'm not going to test you on that, but this is to show you what is the flow of things. And do not be like, oh, x-ray's negative, trauma patient, x-ray's negative, they must be good to go. They need to make sure. That's what that means there. Okay, what are some other injuries of pelvic trauma? So why do we do this? Because again, yeah, there's pelvic fractures, but we're more concerned about all these other soft tissue things that could end up happening. A CT could probably tell us all that, but if I can't get the CT right away because maybe they're not stable, maybe after they're stabilized or through more algorithms, stuff like that, we go to other studies. If you have bladder ruptures, if you're concerned about that, CT cystogram. That's basically a study of the pelvis. They put contrast into the bladder, study the bladder, not pelvis, I apologize. They put contrast into the bladder, they do a CT, and they look at the bladder. Bladder ruptures are really rare in most patients. However, the majority of them occur due to pelvic fractures because that bone is sharp. It rips into the bladder and it ruptures the bladder. Urethral injuries, more common in men than women. Why? More urethra, right? There's more space. There's more frequency for that to happen. You're going to get a retrograde urethrogram. What does that mean? Urethrogram, study of the urethra. Retrograde, putting contrast in through the outside. So they get a catheter into the urethra, little balloon, fill it up with some contrast, take some x-rays, and we'll take a look at some of those. Questions on those two things? Okay. What is a stable versus unstable pelvic fracture? If it's got one fracture, it's stable. If it has two fractures, anywhere within the pelvic ring, it is unstable. This is all connected. I can fracture in one area and still have it hold together, right? I can do that. Think of a donut, right? It's a weird analogy, but think of a donut. A regular, not the cream-filled ones or the jelly ones, right? The regular round donuts. You take one bite of the donut, the integrity of that donut for the most part is still together, right? I just took one bite out of it, it's still together. Still has that little shape, you set it down, it holds the shape. You take 2 bites in 2 different areas, you have 2 different pieces. That donut no longer has that stability. I know, I'm a simple man, I like simple analogies, right? And I like food, I'm from Chicago, it's where I live my life. So, no good food in San Antonio. Anyways, I digress. There's some, but yeah, whatever. Good morning. All right. If you think you know a good place, please come tell me. I'd love to find it. Anyways, so if it's fractured in more than one place, now here's the tricky part with pelvic fractures. The SI joint separation is a fracture. The pubic symphysis separation is a fracture. So that's what gets challenging with the pelvis. Is sometimes when you're looking, you're trying to go, okay, is there another fracture? What's going on? You're looking at more than just the bone. You're looking at those joint alignments. You're looking at that SI joint area. And we'll look at some of these pictures. Okay. I am not giving you something like this red arrow. Right? This is more to let you know that this is a common area of an avulsion fracture, not from trauma. Typically from athletic injuries, right? So you can absolutely end up seeing something like that. Notice it's just pulling that piece of bone away. It's not even fully separated. It just started to pull, that tendon started to pull that piece of bone away, likely from an athletic injury, okay? So I'm not gonna give you something that's small, but know that avulsion fractures can happen in the pelvis too. We have a lot of tendons coming up, attaching to the different areas of the inferior pelvis, and even sometimes in the superior pelvic region. So just know that avulsion fracture is still in your differential for some of these athletic injuries. It's there, not going to waste time going over it, right? You will learn more about this in surgery and ER. There we go. If you really want to get into pelvic injuries, this particular one, if it's still, it should still work. It worked last semester. Sometimes Radiopedia changes their URLs, so if it doesn't anymore, let me know. But you can scroll through these and try to find the different kinds of fractures on the pelvis. So, okay. Normal, right? And now I told you what the abnormalities are because pelvises are hard to kind of see when you're first learning it. So I wanted to point it out at first so you can kind of go through it and know what I'm trying to get you to see. I recognize it's a little fuzzy, so its quality's not great, but able to find the right superior ramus fracture, right here, when I follow my cortex all the way around. How do I know it's a fracture that's not like a fusible? Look, my left doesn't have it, right? Nice part about pelvis is I can compare one side to the other. So if there's something like, is that the patient? Well, look at the other side. If it's exactly the same, maybe it's just a patient anatomy thing. If it's not, then it's probably an abnormality. And then what I have here is this SI joint dislocation. And you're sitting there going, how the hell am I supposed to see that? Well, again, look at my normal. Look at how the interior pelvic rim kind of comes across and how these 2 cortices from the sacrum over to the ilium kind of come together, right? But here, I have this like separation right there. And I wish the screen was working so I could draw it, but. So you see how the sacrum is shifted down, or really what's probably happening is maybe this part of the pelvis is shifting up. I don't know for sure. But you can see that separation of the SI joint. That makes this an unstable pelvis fracture. Sir?
So is the pelvis not sublux? It's still touching a little bit?
No. And I'm only saying that, I get the definition, I'm only saying that because I've always, SI joints has always been dislocations, I've never heard subluxations. So I get the definition of it, but yeah, I'm gonna say just dislocation on that. If you're ever describing that to somebody, just use dislocation, because I've never heard them use subluxation for the SI joints in medicine. And that's a really good question, I don't know why. I'm gonna check with David Caldwell sometime, so he's asked me that before. That's okay. I love how I gave you credit, that's so nice. That's so nice. Now, does he do it the other way too, if it's a negative response? Yeah, okay, good. So yeah, so I'll see if I can find that out for you. I'll ask Major Davalos, when I see him, if not today, then next week. And see if he has an answer for why it's this location and not subluxation for the SI joint. Other questions? Just stretching. Alright, now we can see why, if they're stable, I wanna send them to CT. Look at how much more detail I have on these pelvic fractures if I can send them to a CT scanner. There. SI joint, looks pretty good together, but I got issues with the sacrum in between the lumbar, like you can see it should be the same on both sides. It is not, and I got that fracture there. So again, unstable pelvic fracture. It's fractured on the right sacrum, this is the sacrum right here, and the left ilium. Unstable. Here's another example of unstable with no bony abnormalities. All of the abnormalities are within the pubic symphysis and the SI joint. This is where the pelvis gets a little tricky. Remember that those areas still count as fractures because it's no longer together, right? Fractures. Still gives us unstable pelvis. And how do I know that SI joint is widened? It's widened? Compare it to the other side. Compare it to the other side. They do not look the same. Right? They should be this thin. But even if you're like, I don't know what thin is, I don't know what widened is, compare it to the other side. It's not often, doesn't mean it can't happen, it's not often you get separation of both SI joints. Yes, sir.
Would it be common for an SI joint to separate into pubic symphysis breaks?
So,
You just have that break.
yeah, so let's say it the other way around, right? If you have an SI joint separation, the odds are there's probably some other type of fracture somewhere else in the pelvis. So SI joint separation probably begets another abnormality and it's probably an unstable pelvis. But fracture in the pelvis does not always beget an SI joint separation. Is that?
That makes sense, I was just curious with the pubic symphysis and that.
Oh, like these, oh yeah, not all the time. Yeah, commonly yes. Commonly if I have a widened pubic symphysis, then I'll probably have an SI joint abnormality as well, right? Commonly, but not all the time, right? But the same thing I said about the SI joint, it's probably a safe bet for you with the pubic symphysis as well. If I have a widened pubic symphysis, I would be looking for a secondary abnormality because the odds are there's some other type of fracture or something within the SI joint causes it to be unstable. So either one of these widen would make me want to look deeper to make sure I'm not missing something else because it's probably an unstable pelvis, but I need both to actually call it that. But the other way around, if I have a fracture in the pelvis, it doesn't always beget the widening of the SI joint and pubic symphysis, and I can just have a stable pelvis. But because of the amount of force it takes to do something like this, usually if you see one somewhere else, there's something else causing it to be unstable. It's not always this relationship, right? It's not always pubic symphysis to SI joint. It can be pubic symphysis to fracture of the ilium, right? Or fracture of one of the rami or something along those lines. It doesn't have to be, because all you need is those two areas for things to kind of separate and come apart. Just any two. Does that answer your question? Okay, so I'll make sure, because this can get confusing sometimes. Okay. Stable, unstable. All right, what do we got? Okay, SI joint widening, which SI joint? Ah, good. And then what else? What's the other abnormality?
Sacral fracture.
Left sacral fracture. Good. Okay. Stable or unstable? So this is why it's so funny, like you ask the question and then we have a slide that kind of goes over it, right? So we got, what's the first abnormality that jumps out? Pubic symphysis. Good, so we got that one. So now we're gonna look just a little bit deeper and see what we can find, and it's subtle. It's subtle. There. Compared to the other side. Compared to the other side. Okay? Make sure I'm not missing anything else on this guy.
So let the right
Yeah.
side.
Right SI is good. Now, maybe a little bit of a bigger gap down here, but this is the posterior SI, and it's pretty close to this side, so I wouldn't necessarily have enough to, but what I have here is when I trace my sacrum down, right? I got all this sacrum, I know the shape of the sacrum, comes up like this. I come in here, and then all of a sudden I have a break in the cortex, I have this big fracture kind of sitting here, this funky puzzle piece fracture coming down.
Could you draw it on the main screen, do you mind?
I can't, it's broken, that's the problem, I want to. It's really frustrating. So I come down here, so if I trace the left side of the sacrum and I follow the cortex, it comes all the way down to the coccyx, I'm good. When I do here, and I come down the sacrum, and I come in, my cortex breaks, and then inside here, I got this big, more radiolucent area, kind of jagged puzzle piece fracture that kind of comes on down. It's super subtle. I have this in here because of the fact of what I just said based off of his question. If I have a wide pubic symphysis, I should be looking deeper for that other fracture. Yes?
Okay, so, question then. Alright, so right side midline. Yeah, what's that?
It could be something, it could be a shadow. I don't have an answer for you. Yeah. Right? Could that be something? I don't know. And this is exactly why, this also goes to prove my point. If they're stable, what are they getting next? A CT. Because damn if I can't right? I got sacrum here, I got lumbar spine here, I got like pelvic, like I got so much crud in there to be able to call that and make that maybe, but a CT would be really great to really give me that definition and that answer. Yeah.
Based on pelvic
Anytime there are two fractures, the sacrum is included as part of that pelvic ring. It's all one thing, right? The sacrum is included, the sacrum and then the full pelvis, so it becomes unstable because of the sacral fracture. This right here, that's a phlebolymph. We haven't really talked about that too much yet. That's a phlebolymph, it's a calcification in the pelvic veins. Yeah. Phlebolyth. So phlebe for like vein or vessel, and then lymph, stone, it's not really a stone, it's just more of a calcification. Yeah. Commonly in women, the older they get, the more commonly it is to see the phlebolyths. What else?
Is there anything, I don't know if you
You're
ever
good.
hit that, but like going up into the spine even, you see it starts to like crack right there, like what are we looking at right there? It just doesn't look symmetrical in that general area.
So, if I were curious about that, I would want to get a lumbar spine to look at it a little bit better.
Yeah.
Right, because of the projections, because this is a game of shadows, sometimes when we have multiple things lying on top of one each other here or here, and I'm like, what the heck is going on? That's where you would order the additional imaging to try to take a look at it. But the biggest thing with pelvis is, really what I need you to know, is it stable versus unstable? That's the biggest thing, yeah.
First, this is just the AP, is that coccyx supposed to be perfectly perpendicular compared to the lumbar, or if it starts curving over?
You mean down here?
Yeah, to the left, where you feel more suspicious of that.
Honestly, yeah, so good question, right, on the coccyx. So it, not necessarily with the lumbar, but it should be lined up with the sacrum, because that's where that joint is, that sacrococcygeal joint. So in reality, I care more that it's lined up with the, so here's the coccyx. I care more that it's lined up with that tip of the sacrum than I do that it's lined up with the lumbar spine. This is what I'm watching for, right? So for those that are looking at it, the coccyx is right here, sacrum comes down, the joint space is there, it's lined up, but I'll be honest with you, as far as radiologically goes and even clinically goes, I don't even care, right? Because coccyx fractures or coccyx dislocations, anybody know what we do for it? Nothing. Here's a donut so it doesn't hurt when you sit until it gets better, right? They don't do anything. They don't fix it. They don't surgerize on it. They don't do any of that kind of stuff. They just leave it alone. So more of it, it's not funny, but no, it should line up, to answer your question, with that last sacral segment as opposed to line up with the lumbar spine. Because likely what's happening here is because of this fracture, the other parts of the sacrum are kind of shifting over a little bit because it's not sitting where it should be. And so that's why it's a little bit off to the left, is because of the instability of the sacrum, not necessarily the issue with the coccyx. Right? Because that fracture there, it shifted to the left and a little bit of instability there. Yes, sir?
Just a question, sir. So when we're talking about the ring being stable, unstable, the lower part of the sacrum, if it's fractured, is still considered.
Anything with the sacrum is considered a part of the pelvic rim in this case. Yes.
It seems like it's not part of the cervical.
But it is, I get what you're saying, but it is because if I have a disruption in the sacrum in any way, shape, or form, then there's nothing stopping that from having different pressure and shifting and affecting eventually that SI joint area. And that's why we need to treat any sacral fracture like it's a part of the pelvic rim, like it's a part of stable versus unstable, because what happens when it shifts later on, but just not right now. This was a hard one, guys.
So when you say stable or unstable to get a CT, you're talking about the pelvis being stable or the patient being stable?
Yeah, good question. The patient being stable. Is the patient stable? What are the vitals? Is the patient stable? Right? CT is based off of patient and their vitals. Or if I actually say stable or unstable. And sometimes I'll say that. And then you guys answer something and then you come to talk to me and you're like that word. They're like, oh my God, I overlooked it. Don't overlook it. Okay. Oops, there, all right, I went there. Okay. Yeah, all right. Hey, acetabular fracture. I didn't even get a chance to ask a question. Right or left side? Right side. This is an unfair question. What are these? Are those fractures? Nah, it's a pediatric. Those are things that haven't fused together yet. That one right there. Just the right acetabular fracture. I'm not going to make you say it here, but oh my God, blast from the past. What are the causes of local focal increase and increased density? That's for you guys for studying, right? We'll go through those. All these things are really good for you to kind of just review stuff from previous lectures as you're going through and studying stuff. Questions on that slideshow? Questions on the lumbar spine and the pelvis? That ended beautifully. Take 10, come back to the top of the hour.
So the joints are, they're not just fractured, or is it interchangeable?
Don't get too hung up on it. Sure. Right, don't get too hung up on it. Separation is really probably what's needed. Real medicine has separation just because that can kind of confusing. I say fraction because I want you guys to know that that counts as a fraction. Don't be like, that's not a fracture, so no, it counts. It counts. Yeah.
Every time like I was like,
that's the clue on that. There really isn't a huge range, it's just a little bit of a range, but it's not dark like that, right? And look how smooth the vowel line is. Look at how jagged this is. Those are good. And normally this is a lot easier to show than this HD look because of the draw. Why does it so smooth? Yes. And do I need you to look this hard on just a regular comic art? Not necessarily. Well, you're not a radiologist there, but then also not necessarily. Unless you see something like this, and you're like, I don't see anything else. But I know in order for this to happen, something else has to be there, right? And that's more like I don't plan to be this super subtle, but it's just more showing you like how subtle that other part of the body would be. This is the clue that something else is probably wrong. Let me try to find it. Right? It's so rare for that to happen. Yeah, it's a little bit, right? It's a little bit, but then when you look at the rest of it, you're like, right? And then so I would buy that with this to support it, right? And that's kind of what this was meant to show. Again, it's very subtle. This is a high level read. It's just meant to expose you guys to the aspect of like, oh, if this happens, not impossible. Highly unlikely. Right? Highly unlikely. In other words, if you find it, text me. I want to see that picture. Right? Highly unlikely. But nothing in medicine is impossible. So I don't want you to marry that. Which you don't. I should be able to find it. And then if you're in a clinic and you're in the ER, and let's say not stable, get the fastest in, to the normal. Okay, well, we're going to stabilize the patient. Guess we're going to go on once you stabilize. Going to CT anyways after the time. Is that kind of part of the algorithm? It was like, hey, once they're stabilized, it's normal, but I see possibly a pelvic fracture, but I don't really know what's going on. Once I stabilize them, because we know it's not an internal bleeding, because the fast exam is normal, now you're going to get the angiography, you're going to CT. So I'm getting ready to test, right? But if it's abnormal, you go to laparoscopy because they got to open heart and stop it. And that's really that final part of that algorithm, is the in the end, you're going to get a CT once you stabilize it, it's not internal. Does that make sense? I just kind of stay away from that, because I'm going to go too far down it, but since you're kind of asking me, how would this look? Well, it's trauma, right? So it's not really a nasty workup to you. You know what the problem is. You know what the injuries are, right? And maybe there's no internal bleeding, but you're probably unstable because it's trauma. So you save the life, and then once you're stabilized, you're going to skin. I think in clinic, I think that's a safe thing. I don't think there's anything wrong with you if there's a huge set of life. Because again, even if you're just, stepping out of academia, in my algorithm, right, you're stepping out of clinic. So we're in clinic. Why not? When you get to the clinic, even those who are coming in for like headache or older, right? You have some downtime here where you can go to a scanner, they're waiting for meds to come out, very distressing. Most of it, that's why why not? It's quick, it's easy, wipe the gel off, so again, you're gonna do that with this, all the trauma. Usually when the screen is working, I can talk. So,
Do you also say if it's problematic this way? Or does that?
right, so I'm not married now, because you're right, patients in pain, right? What if they're slightly rotated a little bit, and that's just a projection of the rotation, right? What if that's actually set, but then the separation makes it like the concept of the concept? I don't do that, so I was not married with that, that's the reality there, because I don't have enough information, and it is in line with where it should be. So we gotta always call that. Good?
Yeah, I kept looking over here, I was like,
I
I don't see it.
I know, no, I was just gonna drop that. I wanted to make sure that he has it.
So I figured that, cause I can ask you that. Still. Because I see,
That's your SID.
right, so that's my SID.
Yep, that's why you're doing both
But then
sides.
what are,
So it's just the way that the bones are sitting up and the bones and the colors are overlapping each other. Like the radial, the fractures are not radial, fractures are radial, just don't go. And then, hey, white, that must be something that's likely just either overlapping the bone, something called the usual vessel, all fractures are radial loose. That's all. It'll cover the whole lot. Yeah, that's actually more than just gas. No, it is. That's more than just gas. It's also stupid. So this is all gas. So that's the part where I'm like, shadows, I would probably do a lot of times as well. Try to simplify that when we had, as I was talking about, like eventually one of the things is CT anyways, because you can't tell like this that's something, because I have Satan here, I got L5 coming down, I got there's all kinds of stuff going on. It's just really hard to tell what that might be.
no, so much possible.
Yeah, so that's
They
just
don't look
the
the same.
So maybe they're just a little bit different, maybe they're super subtle, and so like, I would be okay with saying it's I would be okay with this. So let's say you had this and you didn't see this, but you saw that and you called it a mistake. You're not going to be able to know, right? Because eventually the CT is going to tell you the details of that and how long.
Oh, one more thing, sorry. Okay, so for this image,
Yes.
in my head, I'm looking at it, yes, I obviously see that's like not. Because I can see that, but this part,
You're not looking at how this looks. You're following the cortex. You're following the interior pelvic ridge. You're following the cortex with everything. So you're not necessarily looking at these two together. This looks weird. Now it's why.
Everyone got questions.
if that is something,
So yeah, that's
And have personality.
Would you give us an image that's like
I try not to, but
Really?
yes, but not that hard. You know, what can you lower it? I have one of the roles in this on and especially with the fact that after this meeting, it's probably a patient.
How old are you? I like to judge.
Alright, let's jump back in. So really good questions. Somebody else also asked me, what about a woman and who gives birth, right? That pubic symphysis separates. Is that considered a fracture? No, it's supposed to do that, right? And I'll be clear. The reason I use the term, so when we're trying to describe these things, subluxation, dislocation, fracture, not fracture, right? In reality, I think the best way to describe it, what we usually hear is SI joint separation, pubic symphysis separation, right? The reason I use the word fracture is because we talk in those slides about what makes a stable and unstable pelvis, and it's one fracture or two fractures. I'm trying to just keep it in simple kind of terms for you guys and going, that counts. I don't want you to look at it and be like, well, the pubic symphysis is wide and that's not bone, so that's not a fracture, so therefore it's a stable pelvis. No, that counts, right? And that's why I keep using that word, even though fracture is technically bone, I'm using it so you understand that those two abnormalities, two of those things, make it unstable. Now in women, when they give birth, yes, their pubic symphysis separates, so do their SI joints to open up that pelvic rim to allow baby to come through. But then afterwards, it comes back together, right? So in some women, you might notice a little bit what you should have in women, a wider pubic symphysis than in men, right? But it shouldn't be as wide as what we've been seeing in that aspect. But it comes back together. So then the question was, well, what happens if it doesn't come back together perfectly, right? How many have had, females have had children in here? How young are you guys, right? There's a few, right? That can happen. And that's really what a common cause of the low back pain is in women who have had childbirth, is the SI joints have separated. They sit very nice at first. Then they come apart to allow birth, and they come back together, and every once in a while, whether it's automatically or just throughout life, they'll shift. And it won't sit perfect, and they start to get this low back pain. That's where a chiropractor and physical therapy comes in, they can just pop it right back into place. But they're not at any kind of increased risk for like unstable pelvis fractures or unstable pelvis rings or anything like that, just because of that, right? That can cause that low back pain, they'll put it right back into place, and everything comes back to normal. So, that was a good question on that, just wanted to kind of clear that out. All right. Upper extremity stuff. Right? So some of these things at the upper extremity now, when we start getting into this, is we can see it in clinic before we even get an x-ray done. What do you think is going on here? Right? Yeah. That. Right? shoulder dislocation, right? We'll talk about AC stuff too, but shoulder dislocation. Is that an anterior or a posterior dislocation? Yeah, I heard some people say, we don't know. If I look at it, my eyes tell me I'm pretty sure that's posterior because it looks like the glenoid fossa is sitting on top of the humeral head because our eyes want to turn it to the image and make it 3D. We have no idea with just this picture if this is an anterior or posterior dislocation. You need one of those orthogonal views, which we will talk about, to tell you if it's anterior or posterior. But there's enough there to go, yeah, it's dislocated. This is for you guys later. You will learn this a little bit in ortho, but I put it here too because you all can and probably will in your clinics reset dislocated shoulders. This is a common thing that you are going to be able to do and will probably do for your neighbors because they'll come over and they're like, everything's a great doc, hey, help me out here, and you'll do it too. All right. So this entire slideshow is all upper extremity. Okay? A lot of the stuff we already covered. We're just going to kind of review some of it pretty quickly and then talk about the names of different types of fractures and things along those lines. All these things, clavicle all the way down to hand. That's the upper extremity. There's your bony anatomy. Let's start with the clavicle and the AC joint. More anatomy. 112 slides. Look at this. Look at more anatomy. Not testing you necessarily on anatomy. You need to know anatomy, especially bony-wise, to be able to find these abnormalities, but this is one for you guys to review. Okay. Let's look at the clavicle and the AC joint, right? Acromioclavicular joint. We have our acromion process and our clavicle. Now this particular x-ray, it says 30 degrees up. What the heck does that mean? That means instead of shooting the x-ray straight on, they angled the radiation 30 degrees upward or caudal, right? So that way it can project the clavicle above the rib cage better to get a better view of that clavicle and that AC joint. That's standard. You don't have to worry about that. But I say that because you're going to look at x-rays where it doesn't look like this, right? Because that's the normal straight on. They do both. And it should be labeled whenever there's anything that's not just a straight horizontal x-ray beam, so it looks like normal anatomy, they need to label it so you know what they did, so you know why it looks a little bit different. And we'll see what those differences kind of look like. Right? So here's the normal. That kind of curves down just a little bit here, right? This is how the clavicle sits in the body, that sternoclavicular joint. Now look at my caudal. Look at how it like almost looks horizontal, right? That's the difference. It projects it up, and on really good x-rays, it projects it all the way up above the rib cage, so you get a really good picture of it. But that's one of the main differences, okay? But here's your anatomy, here's your AC joint again, clavicle, acromion, all right? Humeral head, glenoid, coracoid, scapular spine. Okay? Knowing the anatomy on this stuff, especially where your acromion and your coracoid is, because when we get to another image, that's going to be your telltale sign to help figure out anterior or posterior dislocation. Okay? We've seen this one before. Here's my normal. Look, 15 degrees cephalic. That means the angle of 15 degrees up. It's not as extreme as the other one we saw, which was 30, but it's telling you, hey, we did this, so that way you know. But compared to my positive yellow arrow sign, and there's my description for you guys. Right mid distal shaft clavicle fracture with inferior displacement and butterfly segmental fragment. Common unit. That's what I care about. Right? Remember, butterfly, segmental, whatever. Is it common unit or is it simple? That's what I need you guys to know. Also, is this mid or distal or I don't know, right? When I told you there's gray areas of kind of like where does proximal stop and mid start? Where does mid stop and distal start, right? So if it's in a gray area, then on a test, I would not give you mid and distal of choices to be able to call this. I would give you one or the other, unless I gave you right mid clavicle fracture and left distal clavicle fracture. That's fair, because it's not the mid versus distal, it's the left versus right that I'm asking you about. And this shoulder even without this right here, is enough to figure out it's a right shoulder. Do we see how we have enough context clues to do, where's the rest of the body? Oh yeah, it's over on this side here, it's over here. So that would be right here, okay. My left is their right, my right is their left, so this is a right shoulder.
Is that because of the coracoid? Is that why you can tell
I can tell because
just because you get the part of the midline?
I got part of the midline, right? I got the whole sternum, I got the thorax, and I know where the rest of the thorax is. That part has nothing to do with coracoid and acromion, that's gonna be your anterior and posterior dislocation, right? But this is just looking at the x-ray, going, I know this is the right shoulder because I can see where the thorax is. And when I play that game of, I'm looking at the patient, we're opposites, that's how I can tell. Yes, sir?
How did you get communism?
1, 2, 3, 4 pieces. Right? So the two main pieces of the clavicle, but then I also have this fragment, and I also have this fragment. So I have 4 pieces. Anything more than 2 is common unit. And then it's an inferior displacement because we name it for the distal segment in relationship to the rest of it. So inferior displacement. And because don't get hung up and go, well, the AC joint looks like it's a line, which means that this was the piece that moved, so it should be superior. Don't care. Don't care. It's always named for where the distal fragment is. Always. Questions on that? Okay. So now this one I can give you mid as a choice. Because there's no gray area here, right? I don't know exactly where distal and mid line is, but it's definitely not that little piece right there. So this would be a fair one to say a right distal clavicle fracture with inferior displacement. And then also gives you a choice of a right midshaft clavicle fracture with inferior displacement. Where we see kind of the difference between the location and where. Okay. We've seen this one before? Right? So left midshaft simple clavicle fracture with apex annulation is the arrow is pointing up. What's going on here? So this one you wouldn't be able to tell with just the image. I would need to give you a history on this. What this actually is, and that's why I wanted to show it to you and tell you how history is important. This is actually a malunion that has recently been refractured to try to get it to heal better. So this is a malunion with subsequent fracture. Can't say non because look, I got cortex in here all the way through, right? I don't have 2 separate pieces. The bottom part, it's all the way, it's connected. So it's healing. This is going to be a malunion. And then it's subsequently fractured. So, not going to do anything like that, right? Not going to be a malunion, it'll be from the other slides that we talked about, or a non-union, it'll be from the other slides we talked about. But just showing you, don't get, non-union jumps out at you, but then you notice that you got to look at the whole thing, that there is still cortex connecting these 2 pieces at the bottom, so it's not a non-union anymore. That's it for the clavicle, guys. Being able to describe the fracture. So I said, like, some of this stuff will go pretty quick, as now that you know your stepwise process. AC joint injury. X-ray. Study of choice. What are the issues? Direct trauma to the top of the shoulder, or with the arm adducted. I almost said abducted. Abducted, right? AC joint injury. Abducted becomes usually dislocation injuries, right? But when we're adducted and we fall on it, we can injure that AC joint. It hurts to lift the arm. You might be able to see the clavicle elevated, right? You could also see that with dislocation injuries. That's where the x-rays are going to come into play, all right? X-ray is your study of choice. If you're concerned about a shoulder dislocation, you can order just the shoulder you're concerned about. If you're concerned about an AC joint injury, you must order bilateral. With and without weight, so also include the weights, and we're going to talk about why. Weight bearing AC joint. How could you weight bear an AC joint? You have them stand on their hands?
Hold on to the
They have 5-pound weights that they hold onto in each arm, and they just relax their shoulders and let the weights pull it down. And we'll talk about why and what that looks like. I must have missed that one. Okay, I left that one. So this is without weights. Okay, the big red circle, I put that on there, but this is without. Normal radiograph. Look what happens to the AC joint. These are both normal. Look what happens to the AC joint when I have them hold that 5-pound weight in a row with weights. See how it opens up just a little bit? That's separating that out a little bit. That's weight bearing in the AC joint. There should have a little bit more of a gap with weights than without. I'm okay with that, right? This is normal. Bravo is with weights, alpha is without weights, to show you what happens when we have them hold those weights, okay? Now when it's injured, look at the injury. Without weights, I wouldn't know there was anything wrong on some of these. With weights, look at the separation of the AC joint. Everybody see that? That's why we give the weights. And it's also why, you're only showing you one picture right now, it's also why we do them bilaterally. So you can compare the uninjured side to the injured side and look at them together. And we'll see a couple of pictures like that, but I can't, because it's wider, I can't fit them both on the same slide, so I have to cut them down and just show you the area that's affected. Yes, sir?
Will the X-ray techs know to do this, or do you need to put it in?
So the order for AC joints is gonna be bilateral with and without weights, and so you order that, and then they know what to do. But you have to still tell them you want it with and without weights, yeah.
So for the degrees of angle, is that something that they do? I've seen
That's-
38, 15,
yeah.
that's just.
It's all gonna be based off of their standard protocol. It's something that they will automatically do. You don't need to get hung up on those numbers. It's whatever that clinic has decided, that's the angulation they wanna use for their AC joints or clavicle, and that's just what they use. Yeah, good question. Cause those are gonna be different, 10, 15, 30, 20, or whatever their radiologists like, really is what it ends up being. Yeah. Normal, first picture, normal. And now what we're seeing is osteoarthritis of the AC joint. So, look at my osteophytes on the end of my clavicle. Maybe even, for those of you that are looking, maybe even a little osteoporosis on this patient. Right, when I compare it to the normal, and even this one here, which is not osteoporosis, look at the difference in densities of my bone. I would say, hey, maybe this could be an osteoporotic patient as well. Now, I can't diagnose that based off of just the clavicle. We have other ways that we've learned to be able to diagnose that if we thought that was a concern, but this would raise questions. But you can get AC joint osteoarthritis, right? Talked about some of those things already in the past, like your athletes, certain athletes, your baseball pitchers, very, very common in baseball pitchers, probably more common than any other athlete for the AC joint arthritis. Because they do things to their shoulder that are not meant to be done in order to throw pitches. For anybody who's into baseball knows that. But I'm trying to think of other ones. Most of your other athletic sports that use the upper extremity, it's more elbow issues than it is AC joint or just overall shoulder. But pitchers for sure. Alright, so again, normal, abnormal. So what is the abnormal? The abnormal is a little bit looking at the joint spacing like we saw, but in this particular one, it's not level. See how level these two are? Look at the acromion, look at the clavicle. If there wasn't a joint there, I could pretty much draw a line almost right across, right? Now we'll allow for a little bit of a variance, like it doesn't have to be perfect, because not all humans aren't built perfectly. So we allow a little bit of a variance. But if I'm looking like I'm on hiking and I gotta take a step up onto that cliff or onto that boulder, that's a separation there. That's why that's abnormal. If I draw this straight across, like I'm jumping down or I'm jumping up, it's not close and lined up like that. Everybody see that? What kind of study is the last one here on the side? That's an MRI. That's an MRI. Never mind the smoothness, right? What When has bone ever looked dark on a CT? When it's an MRI. Bone should still be white and grayish and like bright gray, and then look at, there's my subcutaneous tissue that's more bright than the bone. That is not how CT works. That subcutaneous tissue or fat should always be more radiolucent than the bony area. So it may not be as smooth as some of the other MRs you've seen, but when you take the other context clues that we talked about, MR versus CT, that's where the MR stands out on that one. Right? And this is showing that separation as well. Let's see those, You don't need to memorize this? Yeah.
Sorry, back on the MRI, what's that black arrow pointing?
So this right here, this is meant more to show like a tendon area, like a darkened area in the soft tissue, because you can see how like the main muscle area is dark down here too. It's not an abnormality for you guys to worry about pull out. Again, trying to find pictures that are labeled for what I want to show and like ignore other stuff is difficult sometimes. So don't get hung up on that, because the only MRI I'm asking you to interpret is going to be those spine ones. Anything else you're not going to interpret. Know it's an MRI, know what slice it is, but I'm not going to make you pull out an abnormality on it. You're going to learn this in ortho, right? Different types depending on what ligaments are torn. But I have it in here to show you why we get varying levels, and it's not just well, if it's this much, then you have an AC joint injury, right? Because depending on which ligaments are strained or torn and how many, you're gonna have varying degrees of separation, not from Kevin Bacon, but from the clavicle and the acromion, right? Varying degrees of separation on your x-ray, which is why we can't just say, well, hey, it's abnormal when it hits this level. Because it's a little bit different and your treatments are going to be different based off of how far it is. So that's why we compare our unaffected side to our affected side, or our normal to our abnormal. And here's what that looks like. So which side of the patient is the affected side? The right side. Good. This is with weights, right? And this is what I was talking about. You can see maybe like a little bit of a step there, but it's super subtle. I'm just walking right across that. But then here, we have a big gap, right? So if I draw my line across, I can reasonably go, yeah, that's in line, that's where it's supposed to be, but this side definitely not. Anybody remember what this was? Acromial. Normal variance. How do we verify it's normal? Check the other side. Good. That's it for the AC joints. Know it's with or without weights. Know where those gaps are. And the aspect of where, like, what it looks like when it's abnormal versus normal. If you don't order it with the weights, right, you're going to miss the abnormality. So don't forget to order it with the weights. You need the weights. Shoulder anatomy. Oops, turned it off. There we go. Shoulder muscles. Here's the x-ray. Right? Know your anatomy. Is that an AC joint injury? Probably not, right? Because I'm not focusing on the AC joint, but that projection we talked about, the game of shadows, projecting it up, especially if they're not painful in that area. I'm evaluating the shoulder, not the AC joint here. I'm just looking for any fractures. Okay, there's your lesser tubercle. It's a radial opaque line. Remember, fractures are what kind of lines? Radiolucent. Do not confuse radial opaque lines for fractures. It's either an overlap of different anatomy, like here the lesser tubercle, or just the way the body is sitting sometimes, or something called a nutrient vessel. Sometimes that can just look like a radial opaque line. Fractures are not radial opaque lines, they are radiolucent. Okay? Right. Here's a better breakdown of the anatomy of the shoulder. Okay, labeling all these areas for you to review. Don't forget to go through your stepwise process on these patients. Again, even without the L, I can tell you this wasn't left shoulder because of the context clues of the thorax. Couple of normal views here. So this is one I want you to focus on here for a little bit. We're gonna spend some time on this one. This is a normal view, right? We got our shoulder, focusing on the glenoid area, but this is what's called a lateral Y view. This is one of your orthogonal views that you would need in conjunction with my AP to determine anterior or posterior dislocation. This one I don't have to worry about the acromion or the coracoid, okay? Because I have other context clues here. My humeral head should sit, this is called a lateral Y view because we position the patient at an angle to where we get the Y on the scapula, right? It makes the scapula lateral, not the shoulder, the scapula. So it's a scapular Y view. We call it the lateral view of the shoulder because that's what we do. And the idea is that the humeral head is sitting right in the meat of that Y. And then the scapular spine is coming down here and it's just lined right through the humerus. So if you look closely, you can see how the long part of the scapula is sitting right in that humeral head and just lined up really nice with the humerus. It can be a little off, a little bit angled depending, but it's just lined up really nice in that area, okay? If the humeral head is not sitting here and it's up here in the thorax, right? And this is a dislocated shoulder patient, that's an anterior dislocation. Because think about it, if this is my x-ray film and I'm sitting like this and my shoulder is projecting into my thorax, that means it is anteriorly dislocated. If it's projecting into my soft tissue area, it's posteriorly dislocated.
You said this was shot from lateral to medial? Or this specific Y?
No, it's a lateral view. Technically the x-ray is going from the medial aspect of the scapula through to the lateral one. Because if I'm up against the film, the x-rays are coming this way, so it's hitting the medial aspect first and then coming out laterally. But we just call it a lateral scapular Y view. But humeral head in the thorax, anteriorly dislocated, humeral head in what looks like would be like the tricep area, the deltoid area, the soft tissue back here, posteriorly dislocated. Questions? We'll look at more pictures on this. Yeah.
The wide view.
Uh-huh.
So a normal view we're doing is a anterior shot. Right?
Correct. AP anterior shot. Yes.
So on the wide view, it's always a posterior shot. So
Correct.
Just
Well, it depends on the patient, right? So don't get too hung up on that. It should be done that way. But if I have a dislocated shoulder patient and they have a hard time positioning for that posterior, it absolutely can be shot like, let me do it right here. Kind of like this, it can be shot kind of like this, and they can come through this way if they need to, just because the patient can't get in the right position. So it won't matter, because again, regardless if they shoot it from the way I did it or the other way, they will always turn it again to present to you the way that this looks.
So how do you know if it's which shoulder it's
So, good question, good question. So, for the lateral, you can't tell, you can tell me this is right shoulder. I have context clues. Because regardless of what shoulder it is, or what way they shoot it, it's gonna look similar to this. I need a right or left marker on this lateral Y view to tell me if it's a right or left shoulder. I need to know. I can't tell just for this, right? So it doesn't matter if it's right or left. The theory, or the rule of where's the humeral head applies regardless if it's right or left. If the humeral head is projected into the thorax, it is an anterior dislocation. If it is projected into the soft tissue back here, it is a posterior dislocation, regardless of what shoulder it is. Because on the original flip and what they'll look like and all that, that is a safe rule that you can use when you're looking at the images. But I can't have you tell me right or left on this, just this scapular Y view. If I gave you both pictures and said this is a patient, here are your pictures, you have enough to tell me right or left shoulder, because I've given you this one. Make sense? Okay. Here's kind of what I was showing you up here, trying to show it to you. That's kind of how they do it. They patient at like a 45-degree angle. They're aiming on that scapula right there, and they're just trying to marry and get this beautiful Y letter based off of the scapula. So now you can see here, if it's an anterior dislocation, it's going to project more into that thorax area, right? Because the shoulder is anteriorly moved, so you're going to have lungs and thorax in front of that shoulder, and that's going to kind of project it up there, right? And then if it's posterior dislocated, it's back here in the soft tissue, that's why it's going to project back in the soft tissue here. So that's why we use those rules regardless of what shoulder, just where it's at is kind of how it's going to project. Okay, now there's this one. This is an axillary view. Named because the radiation is going through the axilla. It usually is going this way, so it usually comes up and shoots through the axilla and the film is behind. But again, if I have a dislocated shoulder patient, how well can some of them go, all right, great, let's do this, right? It probably hurts miserably for them. So depending on patient positioning, it might come this way and come through. Either way, it doesn't matter. They're going to present it in this. Now, why is this important? You have got to know acromion versus coracoid and the anatomy. And the reason I say that is because unlike this guy, where I can very simply say, if it's in the thorax, it's anterior. If it's in the soft tissue, it's posterior dislocation. When I get to this one, this, depending, there is no rule on this. There is no rule that the humerus is always going to be pointing to the right. It can be pointing up, it can be pointing down, it can be pointing to the left. For whatever reason, they stopped making rules when it came to this particular x-ray. And they don't care. Like, there is no standard. So, depending, this is normal, depending on where the humeral head is shifted, i.e. past the coracoid or past the acromion, that's how you're going to determine anterior versus posterior. And I'm going to wait until we have the abnormalities to explain it, because it's just easier to see in that aspect. So knowing the anatomy on this is super important, because if you don't know where the coracoid or where the acromion is, then you're not going to know which way this shoulder is dislocated based off of the images. Okay? So again, this is just showing another one, showing how it's shot. All right? This is a humeral head fracture, but it's just showing how certain patients, either dislocations or fractures, this can be very painful for them to get, which is why we usually will lean towards that scapular Y view most of the time, but you might get an axillary view, so we need to know kind of what the difference is. This is the slide we're going to talk about dislocations on. Notice how now it's pointed down. I like this one because look at my anatomy. I have it labeled like this for a reason. I pulled this one from this book, The Radiologist, because I like this, because this points out the axillary. The acromion is lined up with the scapula, which means that's posterior. The clavicle and the coracoid are right next to one another, which means that's anterior. Therefore, on your axillary view, if your humeral head is not sitting in the glenoid and it is over or past the acromion, that is a posterior dislocation. Okay? If your humeral head is over or past the coracoid, not the clavicle, because you don't always see that, but the coracoid, that is an anterior dislocation. You don't need both the scapular Y view and the axillary to be able to determine anterior or posterior dislocation. You need the AP, which tells you it's definitely dislocated, and you need either the scapular Y view or the axillary to tell me if it's anteriorly or posteriorly dislocated. I also can't tell you what shoulder this is from just this x-ray and the axillary either, because I don't know. I just have shoulder, acromion, clavicle, some ribs, like I don't know which shoulder it is, so I need a right or a left. Now if I gave you the AP with that, now you have enough context clues to say which one it is if that was the case. But you can't tell me if this is a left or right shoulder. There's no way. And it doesn't matter if it's pointing down, left, right, it doesn't really matter. You can't tell me if it's left or right.
Let's walk the dog real quick. So
Go for it.
I turn my iPad sideways and I see the acromion on the back of the scapula, then I can see my ribs on the right.
Don't play that game. Don't do it.
I walk that dog.
Don't, yeah, put the dog back in the kennel, stay in the lily pads. Stay on the lily pads, don't do it, right? Don't do it, right? Theoretically, if you wanna walk it that far, maybe, but do you really need to do that? No, because I'm telling you, I'm gonna give you a right? I'm telling you. So don't waste brain power on that. You got farm coming up on Monday. Save those cells for that. Okay. Questions on this? Does that make sense from the acromion and the coracoid point of view? Okay? Alright. Pediatric normal radiograph. Now, there were some that asked me before, when we looked at Salter-Harris fracture, why things look a little funky in this area. This is a unique area, I said we're gonna come across to it. Look at my physes and my growth plate in the shoulder for a pediatric. It's got that fun little kind of pointed area there. That's what it's supposed to look like. It's one of the only joints that has a physes that looks like that. So when that ice cream cone kind of slipped off and it looked a little funky on this side, we're trying to figure out how does it go back on. It's because of the way that this growth plate is in the humeral head. Okay, this is normal, but again, not gonna, unless it's a Salter-Harris fracture, not having you interpret peds and tell me which growth plates are normal, which growth plates are fractures. It's too advanced. You won't even learn that in pediatrics. I even confirmed that with Major Klein. She's like, nope, that's why they have special radiologists. But yeah, it's good, that's what I'm telling them. All right. Reference slide only, but, I was gonna say MRI, CT, MRI. All right, this is showing you how we can see the supraspinatus tendons, the nerves and the vessels. We can make out the labrum, so you can see what an MRI will show you, right? I'm not gonna make you pull out labral tears. We can look at a couple just so you got a good idea what it looks like, but I'm not gonna make you pull out those abnormalities. Shoulder dislocation. Okay, let's talk about it a little bit. Anterior is your most common. Anterior is your most common type of dislocation. Why? There's nothing in the way. It's way easier for it to dislocate anteriorly as opposed to posteriorly. I got a scapula and a bunch of musculature and all that other kind of stuff trying to keep it in place. So anterior dislocations are very, very common. How do they do it? Fall on externally rotated, abducted, and extended arm. So a throwing position, I fall, ow, it comes forward and anterior dislocates, right? So yeah, subcoracoid, humeral head lies subcoracoid. Why? Because we can talk about that in the axillary view. How it comes forward past the coracoid, that's the anterior dislocation. You can have a posterior dislocation, it's less than 4%, most commonly in your seizure patients, right? Generalized seizure patients or somebody who got electrocuted. Because everything tenses up and it takes that kind of force. And the amount of force that is put on the body during a seizure and electrocution is more force than any of us can lift in the gym. Like whatever you can do in the gym, you can multiply that by multiple when it comes to what your body does when you have a seizure or when you get electrocuted. Right? And so that's what causes a lot of our posterior dislocations. So just kind of keep an eye on that, but between that and the x-ray, that's where you can pull that out. Inferior dislocation, super, super rare, right? However, that bottom line tells you, we haven't covered on x-ray because you're gonna see that patient, you're gonna know. That arm is sitting like this, and they can't move it. Because just think about the anatomy. Inferior dislocation. The humeral head has come down, right? It's sitting down in this area. I can't, there's nowhere to move it, right? And they sit like this. So when the patient sits like this, then this is gonna be an inferior dislocation. It's gonna be a high energy, extreme abduction, and the odds are they've torn their labrum, they've torn their calf, so they got all kinds of damage in there. It's super rare, less than 0.5%. You could potentially go your entire career and never see an inferior dislocation of the shoulder. Alright? That means you would need to see one, right? You would need to see 200 shoulder dislocations in hopes to come across one inferior dislocation. So it's pretty rare. Alright. So shoulder joints unstable by nature. Why does the shoulder joint dislocate so much? Look at the x-ray. There's nothing holding it in place except for muscles, right? It just sits in that glenoid fossa area. It's not married to that scapula. It's not like it just sits there, right? So it's very, very common because of that area. So a lot of times you get labrum damage, ligament damage. X-ray is going to be your study of choice. Those are the three views we talked about. The key thing is you're going to set these back, right? you're gonna put these back in place. Always, 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 always get post-reduction films. If you've done an x-ray, you saw it was dislocated, you put it back in place, always get another x-ray. A, you wanna make sure you put it back in the right place, right? That's important. But two, there's gonna be some abnormalities or fractures that maybe you didn't have on the initial x-ray that you now could see from either the trauma of when it dislocated or the trauma of you putting it back in place. And here's what they are. So you have your Hill-Sachs fracture or Hill-Sachs deformity that sits on the posterior lateral humeral head. It's like a depression fracture, but the humerus head is supposed to be nice and smooth and pretty, nice and smooth, and we get like this little depression fracture kind of sitting on the top of the humeral head post-reduction, right? Think of, there's a hill of the humerus on the top of the hill, Hill-Sachs. Okay? The other one you can end up with is your Bankart lesion. B for Bankart, B for bottom. Okay? It's on the anteroinferior or bottom area of the glenoid fossa. These are fractures that can occur from the trauma of the dislocation, either the dislocation or the relocation of the shoulder. You may not have them on dislocation x-rays, but then when you relocate it, they may now be present. So that's another reason you have to get those post-reduction films. If you were to get an MRI, you could never take enough injury or labral tear. You don't get an MRI just for one shoulder dislocation, right? Unless after they heal up from it a couple weeks ago, they're still having issues. They're having some catching, locking. You'll learn about that in ortho. But for just the shoulder dislocation, all you need is the x-ray. Okay? But then always get those post-reduction films because you're looking for either the Hill-Sachs or the Bankart lesion. Okay? If you end up with a patient who comes in and you get a normal x-ray because their shoulder's just hurting them, they haven't dislocated it, and they have a Hill-Sachs or maybe a Bankart lesion, the odds are they probably dislocated their shoulder in the past. And you can ask them that. And they're like, oh yeah, I dislocated it when I was playing football for college or whatever the case was. No big deal, I never went and got seen for it. Well, dislocation and relocation causes a small fracture, you're not going to do anything about it. The humeral head is going to look like this. It's just going to heal like this, like it's not going to magically go back to the nice round humeral head. They're just going to have that Hill-Sachs deformity for the rest of their life. But a lot of times you'll find a patient who had dislocations but he never got seen, never got x-rays for it, they pop it back in themselves by finding these Hill-Sachs or Bankart deformities. Okay, here's this slide showing you the differences in the dislocation of the scapular lining. We talked about it already. Now I have it pointed out on here and given you normal, posterior, anterior. Normal, posterior, anterior. If you pay close attention to the wide view, if you're really good with anatomy, outside of using that, you can look at my scapula and go, oh hey look, this is the acromion, this is the coracoid. So it still fits with what we talked about in the axillary. Here's the acromion, here's the coracoid. So if it's past the acromion, it's a posterior. If it's past the coracoid in that area, it's an anterior. It still works on this one, but you don't necessarily need the anatomy of the scapula in that area to figure that out because you'll have some thorax or some soft tissue. Right? Yes, sir. So look at how it's kind of clipped off here a little bit. They probably just had the patient kind of out a little bit more, and then they cut it. So the odds are it was there, and they were just trying to show this. You can like zoom in and cut stuff out of x-rays, especially digitally. So what these are basically done is they really wanted to zoom in on just that scapular humerus. So if I had a whole x-ray, you would still be getting some ribcage in there. Yeah, they just, because this would not be acceptable, right? I can't see that humeral head. I can't see the whole humerus head. I can't evaluate that. So these are just kind of condensed down. Okay, so if I got this, talk to me, Goose, what do we got? Anterior dislocation of the right shoulder. That's it. It's not where it's supposed to be. It's a right shoulder. kind of hard to tell. I mean, it looks like it's dislocated here on the AP, right? Because of the gap I have between the scapula and the humeral head. It doesn't look like it's sitting there. But is it dislocated? Is it sublux? I don't know. Oh yeah, no, it's dislocated. It's nowhere in that at all. So anterior shoulder dislocation. Good. This is for pediatrics. Pediatrics is hard to tell if they're dislocated or not, right? Talked about that. Joints are bigger, things are funky. But when you learn that the physes is this nice, lovely triangle or the roof of a house, if you see a horizontal physes on a humeral head on a kid, that's a dislocated shoulder. Not gonna test you on that, but know that if you get that, you should have the roof of the house if the physes isn't fused yet. And if it's not, what we call light bulb sign, right? I just like the roof versus the horizontal for me, but it looks like a light bulb, bless you. That's a dislocated shoulder pediatrics, yeah.
You mean that it was dislocated or?
No, it is currently dislocated.
Oh, okay.
It is currently dislocated. Because it comes out and for whatever reason with peds, because again, there's less to support it, it just kind of rotates a little bit too, and the way it kind of shows the physes like that. Here is one with the axillary view and the lateral wide view together to marry that acromion. Right? Posterior dislocation. Past the acromion, past the acromion. Here's one on the axillary wide view. Make out a Bankart lesion. Now most of these you're going to use the AP to look at that, but see what my glenoid looks like normally, and then see my fracture here in my glenoid on this area. Hard to see on this. Highly recommend. Most of the time you're going to be using your AP to find those Bankart lesions, and that's what I'm probably going to be giving you, because that's where you're going to see most of it. But know that other images can be used to help adjunct things and help you out. What I could do is give you like this axillary view along with an AP with a Bankart lesion and try to give you more views. So that way if it's like questionable, you have like an additional view to help support, right, what you're seeing sometimes, because you need multiple images sometimes to support that. And we'll look at that when it comes to the thumb. Another one showing you Hill-Sachs, Bankart lesion compared to my normal. So last slide, FYI, this is just showing you what labral tears look like, or rotator cuff tears, sorry. So you can see your supraspinatus tendon here. So I want you to look and see the supraspinatus tendon. It's got all the fibers coming through and connecting in. And then here, I got that same tendon that's got the tear in it. If I follow it down, I got the gap. That's how MRIs will find those rotator cuff tears in that aspect. Okay. This is all labrum. This is all labrum down in here. The white is labrum, labrum. Biggest piece out of this is recognize your Hill-Sachs lesion, your Bankart lesion, and which way is the shoulder dislocated based off of the anatomy and the clues that you have. Questions on that?
Sure.
Ma'am.
So do they both occur, like if one's there, then the other's also there? Is that always like that, Hill-Sachs and Bankart?
Not all the time. They're not always together. You can have one or the other, or you can have both. Good question. Sir?
So the Bankart lesions are coming up, at least to me, they look more radio opaque, like it's a brighter line than a darker. Am I seeing that?
So
That one I don't see it as much on, but on the AP ones,
yeah, so this one is hard. This one is hard to see on the Bankart lesion. Let me go back to the other one here real quick. There we go. So here's another AP one, right? The fracture is kind of this bone that's kind of peeling off right here on that slide.
that is more obvious.
Yeah. So again, some X-rays are more challenging than others. I'm going to do my best to give you ones that are not ambiguous in that aspect. Because this one for the Bankart is really, really hard to pull out. Honestly, I spent time trying to look at the white. I can't get rid of the white arrow, but it's a really good Hill-Sachs.
So, it is really hard to pull on that one. I would not give you one like this and say, find the bank card lesion. Or like, you make that the answer. I wouldn't do it. It'll be more present. You see other hands? Okay, have a good weekend. Good luck with farm on Monday. All right, you guys got this. It'll be good. It'll be great.